So hello everyone, our today's subject is periodontics. So let us discuss our first question. The first question is laminin, it is found in gingival. Well, the laminin, it is found in the basal lamina. So this one is the basal lamina and laminin, it is found in the basal lamina. So the basal lamina, it consists of mixtures of collagen, laminin. So laminin is remember laminin, it is a glycoprotein. So laminin, it is found in the basal lamina, that is part of the gingival tissue. We know that the basal lamina, it consists of lamina lucida and lamina densa. So the lamina densa, it contains type 4 collagen that contributes to the structural integrity of the basal lamina and provides the tensile strength to the tissue. Whereas the laminin, it is mainly seen in the lamina lucida. So laminin, it is responsible for cell adhesion and anchoring the basal epithelial cells to the basal lamina. Now what are the other components that are seen in the basal lamina? So number one is laminin. So laminin, it is a glycoprotein. Already discussed that it is a glycoprotein. It is a major component of the basal lamina. It plays a role in cell adhesion. So the laminin molecules will bind to the cell surface receptor and it will help to anchor the epithelial cells to the basal lamina. Apart from that, it contains collagen fibers, that is type 4 collagen fibers. So it forms a network that provides structural support to the basal lamina. Apart from that, you can see is intestine, that is nitrogen. So it is a glycoprotein that helps to link the laminin and collagen type 4 fibers in the basal lamina. And last is perlecan. So it is a large, what is perlecan? It is a large heparin sulfate proteoglycan that is found in the basal lamina. It interferes with various molecules including the growth factors and contribute to the structural integrity of the basal lamina. So the question, the laminin, it is found in the basal lamina. Now the basal lamina, it is important for various several reasons, that it provides the mechanical support to the overlying epithelium. It acts as a barrier that separates the epithelium from the underlying connective tissue. It promotes in cell adhesion, like it has a laminin glycoprotein that helps to attach cells to the extracellular matrix. So answer would be A. The next question, the hydroxyapatite, it consists of all except. Well, the carbon, it is not a component of hydroxyapatite. The hydroxyapatite, it consists of calcium. It consists of calcium, phosphate, and hydroxyl ions. So carbon is not a component of hydroxyapatite. So remember the hydroxyapatite formula, that is So it doesn't consist of carbon. The proliferation of keratinocytes, it takes place from the proliferation of keratinocytes, it takes place from both the basal layer and suprabasal layer. So the proliferation of keratinocytes, that are the primary cells of the epidermis, they are responsible, the keratinocytes, they are responsible for producing protein, that is keratin. So it occurs in the basal layer of basal layer, that is also known as stratum basale. So the suprabasal layer, it consists of cells that have already started the process of keratinization and are gradually moving toward the skin surface. So the proliferation of keratinocytes, it takes place in the basal layer. So the keratinocytes here are actively dividing through a process that is known as mitosis. So as the new cells are formed, they move upward through so in the basal layer, the keratinocytes, they are constantly dividing and producing new cells to replace those that are shed away. So as the keratinocytes, it's moved through the suprabasal layer, they undergo changes in their structure, including the accumulation of the keratin protein and formation of structures like keratinosomes. So the keratinocytes in the basal layer, they are actively proliferating. The cells in the suprabasal are transitioning toward becoming fully keratinized. So the answer is both of above. The color changes of gingiva, it is diffuse in, well, the color changes of gingiva, it's diffuse in herpetic gingivostomatitis. So remember this chart, it is marginal in acute necrotizing ulcerative gingivitis, and it is patch-like or diffuse in acute reaction to the chemical irritants. So in case of acute herpetic gingivitis, the color changes in the gingiva, they are typically diffuse. So this condition, it is characterized by inflammation and presence of oral sores. So in acute gingival inflammation, the color can vary in nature and distribution. So the diffuse color, it is result of widespread inflammatory response that is triggered by the viral infection. The gingival color in herpetic gingivostomatitis, it is diffuse. So answer would be diffuse here. The difference between the acute necrotizing ulcerative gingivitis and acute herpetic gingivostomatitis, it is, the answer is D, all of them. Anag, it occurs in the dental papilla, whereas acute herpetic gingivostomatitis, it appears as diffuse erythematous gingiva. Anag, it is limited to the dental papilla, whereas the acute herpetic gingivostomatitis, it presents as a widespread diffuse erythematous gingiva throughout the oral cavity. Nag occurs in young children, whereas acute herpetic gingivostomatitis, it is more seenly in the children, especially during the primary herpes simplex infection. Anag can cause necrosis, whereas the Sonag, it is characterized by necrosis, dead tissue and ulceration of gingiva that can result in punched out appearance. Whereas acute herpetic gingival they are seen as multiple ulcers and blisters that could be the nug. It is mainly caused by fusospirochetes, whereas the primary herpetic gingivitis it has a viral etiology. So you see here a punched out gingival margin with pseudomembrane, whereas in herpetic gingivitis there is erythema, vesicular eruptions, the vesicles that rupture and leave a depressed or spherical ulcers. So remember these differences. So your answer would be all of them. The calculus, it is attached to tooth surface by the calculus. The tooth surface is naturally coated with a thin layer of organic material that is known as pellicle. So calculus, it can initially attach to this pellicle. Over time, the dental plaque accumulates on the tooth surface. The bacteria in the plaque, it can penetrate into the cementum that can contribute to the attachment of the cementum. The third calculus can also attach to the tooth surface through mechanical means. It can become logged to surface irregularities and cause roughness on the tooth enamel and cementum. So it can tightly log to the surface irregularities and the roughness on the tooth surface enamel and cementum. So that make it difficult to remove through regular brushing or cleaning. So your answer would be all of them are correct. Which type of the gingival enlargement it is seen in puberty? So gingival enlargement in puberty, it occurs in both male and female. So in puberty, some individual may develop a type of gingival enlargement that affects the interdental papilla and facial gingiva, both they are enlarged. So there is prominent bulbous appearance of the interdental papilla, and can extend to involve the facial gingiva also. So your answer would be B here. The ecological determinants of plaque depends on all except. The answer is C, interdental papilla. The sugar content of one's diet, it is a critical ecological determinant as it influences the availability of the fermentable carbohydrates. For oral bacteria, that can lead to production of acid and development of the dental plaque. Host resistance, the host natural defense mechanism, they are the significant determinants of the plaque ecology. The status of dentition, the presence and condition of teeth, it plays a role in the plaque ecology. Tooth surfaces, they provide attachment site for the oral bacteria, and the status of dentition that can affect the development and the retention of plaque. So your answer is interdental papilla. The type of the dental plaque that is critical in the calculus formation is the supragingival and tooth associated subgingival plaque. So the supragingival calculus is the plaque that is formed above the gum lines. So it can directly mineralize into calculus where the mineral source is the saliva such as calcium and phosphate. The tooth associated subgingival plaque, it is formed below the gum lines. So it can also undergo mineralization and contributes to the calculus formation. The source here would be GCF. So the minerals that are necessary for the calculus formation, they are more readily available near the tooth surface. So the minerals they comes from the source is saliva. The bacteria in the gingivitis, they are located in the bacteria in the gingivitis, they are located in the gingival clavicle fluid and connective tissue of the marginal gingiva. So the bacteria associated with the gingivitis, they are typically found in the dental plaque. So option D is the answer here. The glucose level in the gingival clavicle fluid, they are 3 to 4 times greater than the serum level. So the health of the oral cavity, including presence of plaque, it can influence the glucose level in the GCF. So when there is inflammation in gums, such as gingivitis or periodontitis, there can be increased blood flow to the affected area, so leading to the higher glucose level. The difference in color between the supra and subgingival calculus, it is related to presence of hemoglobin and the effect of hemolysis. So subgingival calculus, it is situated below the gum line. So over a time, the hemoglobin in the blood, it can be released and become trapped within the subgingival calculus. So that gives a reddish brownish color. So hemoglobin, we know it contains iron, so that can oxidize and contributes to the discoloration of the calculus. Whereas the supragingival calculus, it is often lighter in color. The mineralization of the dental plaque, it proceeds from the mineralization of dental plaque, it proceeds from the periphery toward the tooth surface. So that involves the deposition of minerals, that is the calcium and phosphate, primarily from the saliva toward the tooth surface. So it's from the periphery toward the, so the source here is saliva. In supragingival, for supragingival, it's the source is saliva, and for subgingival, it's GCF. Gingivitis in HIV positive patient, characterized by well-demarcated band of intense erythema at the gingival margin, not associated with bacterial plaque, and which does not respond to conventional plaque removal procedure. It is called as linear gingival erythema. So it is a distinctive form of gingival inflammation that is associated with HIV positive individual. So this is the linear gingival erythema that you can. The function of the Langerhans cells is, the Langerhans cells, they are the dendritic cells that fall under the category of antigen presenting cells. So their role is to recognize the antigen, capture them, and then present them to the T lymphocytes. So that process, it is a fundamental step in initiating an immune response. So moving to the another question, MC calls festune, they occurs due to the trauma from occlusion. So these are the MC call festune. and this is the Stillman's cleft. Now let us understand the difference between them. The Stillman cleft, it is characterized by narrow triangular shaped recession of the gingiva. So this triangular shaped recession of gingiva. So as the recession it proceeds, it widens, exposing the cementum on the root surface of the teeth. So when the recession it reaches the mucogingival junction, the area become inflamed. So they are generally, the Stillman cleft, they are generally seen due to difficulty in maintaining adequate plaque control. Whereas the Mcqs festoon, they are the thickened rolled band of the gum tissue that is generally seen in the canine region. They are generally associated with the concept of trauma from occlusion. So the treatment given is the occlusion adjustment. However, it also describes the inflammatory changes of the gum tissues at the margin. So Mcqs festoon, they generally occur due to the trauma from occlusion. Moving to the next question, the diameter of the medium bristle toothbrush, it's the soft brush, it has a diameter of 0.2 mm. The medium brush, it has diameter of 0.3 mm. The hard brush, it has a diameter of 0.4 mm. So answer is B. So in inches, suppose if they ask in inches, then your answer is the diameter of the medium brush is 0.012 inches. The next question, the bone marker for periodontal diseases are all accept. So bone markers, they are the substance in body that can be measured to assess the bone metabolism and the bone health. The option first, hydroxyproline. Hydroxyproline, it is a component of the collagen, that is a major structural protein in the connective tissue of body. So it can be measured in the context of bone health assessment. Osteocalcin, it is a protein that is produced by the osteoblast and it is involved in bone mineralization. So it can be used as a bone marker to assess the bone turnover and health. So osteocalcin, it is relevant to the periodontal disease as it reflects the changes in the bone metabolism. The CRP, also known as a C-reactive protein. The CRP is C-reactive protein. So CRP is an inflammatory marker and it is not a bone marker. So it is an indicator of systemic inflammatory response that is associated with the gum diseases. Pyridinoline, it is a marker for the bone resorption and it is used in the assessment of the bone loss as it reflects the breakdown of the bone. So your answer would be C here. The main component of calculus, it's the hydroxyapatite. So which is the main component of calculus? So remember the hydroxyapatite, it is present in 58%. Magnesium whitelock, it is present 21%. The brushite, it is 9%, and octacalcium phosphate, it is 12%. So the main component is hydroxyapatite. So the inorganic component of the calculus, they includes the calcium, phosphorus, carbon dioxide, and small amount of magnesium, sodium, zinc, strontium, etc., silicon, iron, and fluorine. The crystalline structure, more than the 2/3 of inorganic component, it has a crystalline structure. So there are what are the crystals? Main crystals, they are hydroxyapatite, magnesium whitelock, octacalcium, and brushite. Remember, the brushite, it is more common in the mandibular anterior region. So for MCQ point, very important, brushite, it is seen where? In the mandibular anterior region. And magnesium whitelock, it is mainly seen in the posterior region. So this one is important. Many MCQ have been framed from these questions. Coming to next question, hypersensitivity reaction to component of chewing gum that presents a mild marginal gingival enlargement, it is known as plasma cell gingivitis. So plasma cell gingivitis, it is inflammatory condition of the gums that is characterized by abundance of plasma cells. So these conditions have been associated with involvement of chewing gums. It can be triggered by certain components in the chewing gum, toothpaste, or other oral hygiene products. So plasma cell gingivitis has been linked to an allergic reaction. That are present in the chewing gum. The substance could be flavoring, preservative, or additive that could be added. So the body immune response to this allergen can lead to inflammation and increased presence of plasma cells. Dowager's hump, it is seen in which disease, in which systemic disease of interest to periodontics? The answer is osteoporosis. So this one is Dowager's hump. So it is a term that is used to describe an abnormal rounded curvature of the upper spine, specific the thoracic spine. So that can significantly affect the patient posture and overall appearance. So it is primarily related to osteoporosis. So that there would be a weakness of bone, making them more susceptible to fracture. So in an individual with osteoporosis, the bones become less dense and they lose their structural strength. So that can result in vertebral compression. So these are the fractures that can occur in the vertebra, or so that can lead to forward curvature of spine, ultimately formation of Dowager's hump. So here the spine would take, but as the osteoporosis progress and there is more vertebral compression, the Dowager hump, it can become more pronounced and noticeable. So the spine would take a rounded appearance. So this rounded or hunked appearance occurs due to the weakened bone or the fractures. The likelihood of restoring tooth stability, it is related to extent of mobility, and it is inversely proportional. So as the alveolar bone is lost, the tooth may become mobile or loose. So the extent of mobility uh, can vary, with some tooth having slight movement and other having significant mobility. So when the mobility increases, then there is decrease in the stability. So there is decrease in restoring the tooth stability. So that is why they are inversely proportional. Matrix metalloprotein, they are member of large subfamily of proteolytic enzymes that are. So matrix metalloproteins, we know that they are also known as matrixin. So remember, these matrixin, they play an important role in breakdown of extracellular matrix. So they are involved. Remember, they are involved in breakdown of extracellular matrix. So that is that is a network of proteins that provide structure and support to the various tissue. So MMP are enzymes that can break down different type of protein that are present in the extracellular matrix. So they are involved in process like tissue remodeling and repair. So remember, these MMP, they have three main components. One is propeptide, other is catalytic domain, and last one is C-terminal domain. So propeptide, it is like a lock that keeps the enzyme inactive until it is needed. So removing the propeptide would activate the enzyme. So catalytic domain, it is where the enzyme does its works. So it has a special zinc ion. So this catalytic domain, it has a zinc ion that is important for its functioning. The C-terminal, that determines how the enzyme interact with other proteins, and it controls what it can break down. So MMP, they are member of large family of proteolytic enzymes, which are zinc and calcium. So MMP initially are as in inactive form, like locked enzyme. So they become active when the propeptide is removed. So zinc, it is a metal that is essential for MMP to work. It is found in active state of catalytic domain where the enzyme does its job. So in order to prevent MMP from being too active, the body has tissue inhibitor of matrix metalloprotein, so that can bind to MMPs and control their activity. So let us consider the role of MMP8 in periodontal disease. So suppose MMP8, it targets the collagen, that is a major component of periodontal ligament and gingival connective tissue. We know collagen, it provides strength and structure to these tissue. So in periodontal diseases, the inflammation and infection lead to accumulation of plaque and calculus that leads to activation of inflammatory cells like the neutrophils. So these neutrophils would release MMP8 that starts to break down the collagen fibers. So the continuous action of MMP can result in a destruction of the collagen scaffold that supports the teeth. So this loss of collagen and tissue breakdown, it can lead to clinical manifestation of periodontal disease like the recession, tooth mobility, and ultimately the tooth loss. So controlling MMP activities are essential in preventing and managing the periodontal diseases. So here your answer would be matrix metalloprotein. They are member of zinc and calcium dependent. Coming to the next question, commercially available OmniGene, it is a type of nucleic acid probe. So nucleic acid probes, they are used to detect DNA sequence and they are used to identify particular organisms or genetic markers. The gingiva become more red than its normal color when there is increase in vascularization and a decrease in keratinization. So color of healthy gingiva, we know it is pink due to combination of factor, including the natural color of the blood vessel and presence of protective layer of keratinized epithelium on the surface. So when there is increase in vascularization, means there is increase in the blood flow, and a decrease in keratinization means thinning or loss of protective outer layer. So that causes gingiva to appear more redder than its normal pink color. So the reduction in keratinization makes the gingiva more susceptible to damage and color changes. Limus lysate procedure, it is used to measure the endotoxin activity in the pocket. So it is a procedure that is used to measure the endotoxin activity in pocket. So this procedure, it is employed to detect and quantify the presence of endotoxin, which are the component of outer membrane of the gram-negative bacteria. So it is used to assess the bacterial activity in periodontal pocket and reflect the presence of gram-negative bacteria and their endotoxin. Sulcular epithelium, well, the sulcular epithelium, it is non-keratinized, but it can be keratinized when the inflammation it is reduced. So this transformation is due to the response of tissue to the presence or absence of inflammation. In the healthy stage, the sulcular epithelium, it remains non-keratinized, but it can undergo changes when the gingival health it is restored. The histopath peak of chronic gingivitis, it is there is infiltration of neutrophils, lymphocytes and plasma cells. So you can see combination of these immune cells in the affected area. Gingival crevicular fluid, it reaches the maximum level after how many days of gingivectomy? The flow of GCF reaches its maximum level after 7 days following a gingivectomy procedure. The prerequisite for the plaque formation, it's the dental pellicle. So dental pellicle, it is a thin acellular proteinaceous film that forms on the tooth surface. It serves as initial attachment surface for the dental plaque, while the glycoprotein, dextrans, mucopolysaccharides can be component of mature dental plaque. The formation of dental plaque begins with the development of pellicle layer on the tooth surface. So the pellicle allows bacteria in the oral cavity to adhere to the tooth and initiate the plaque formation. What is the idle probing force? So the idle probing force in periodontal probing, it's 25 pounds or 0.75 Newton. So this force, it is applied to assess the periodontal pocket depth and health of the periodontal tissue. The best clinical indication for gingival inflammation, so bleeding on probing, it's the best clinical indicator for gingival inflammation. So when the gingival tissue they are inflamed, they are more likely to bleed when probed. So this bleeding on probing, it is a common clinical sign of the gingival inflammation, and it is used as an indicator for the gum health. So it is a sensitive indicator that can help diagnose and monitor the gingivitis, that is early stage of gum disease. While other changes like color, stippling, swelling may also occur with the gingival inflammation, but the bleeding on probing, it is a reliable and widely used clinical marker. The periodontal destruction, it occurs in an episodic fashion. So that means the process is characterized by periods of activity and inactivity, leading to intermittent episodes of tissue destruction. So during the active phase, there is loss of collagen and alveolar bone that results in a deepening of pocket. So these episode of periodontal destruction, it can vary in intensity and frequency from the person to person. So remember, periodontal disease, it's not a continuous steady process, but it occurs in cycle with period of exacerbation and remission. So that is why the answer is B. In case of combined gingival enlargement, the inflammation is usually a secondary complication. So in case of combined gingival enlargement, the inflammation, it is usually a secondary complication. So that means that inflammation, it is not the primary cause of gingival enlargement, but rather it occurs as a result of other conditions such as medication induced enlargement or the fibrotic changes. So in these cases, the inflammation is additional factors contributing to the overall gingival enlargement, so creating a combined gingival enlargement. The inorganic component of subgingival plaque, they are derived from the GCF, and for the supragingival plaque, then the answer would be A. So if the question states for the subgingival plaque, then the answer is GCF, and if they state saliva, then the source for the supragingival plaque, it's the saliva. Gingivitis is associated with mouth breathing, it is of diffuse in nature. So the gingiva here would appear red and edematous. So as you can see here, the enlargement is diffuse. The inorganic component that is present in plaque in the trace amount include all of the following except. The inorganic component in the plaque that is present in trace amount include all of the following except. Well, the predominant form, they are the calcium and the phosphorus, while sodium, potassium, fluoride, they are available in the trace amount. So your answer would be phosphorus. So phosphorus and calcium, they are present predominantly, whereas sodium, potassium, fluoride, they are in trace amount. Coming to the next question, the alignment of the long axis of hydroxyapatite crystals of alveolar bone in respect to collagen. The alignment of the hydroxyapatite crystal in alveolar bone with respect to collagen fibers, they are parallel to each other. So they are parallel that allow the bone matrix to effectively withstand the mechanical stress. We know that the hydroxyapatite, it is the mineral component of the bone, and it is primarily composed of calcium and phosphate ions. Collagen, on other hand, collagen is a fibrous protein that provides flexibility and tensile strength to the bone tissue. So the long axis of hydroxyapatite crystals, they are parallel to the collagen fibers. So that means that the hydroxyapatite crystals, they are deposited on and within the collagen fibers in such a way that they run in the same direction as the collagen fibers. So this alignment would allow for number one, the strength. So the collagen, it provides bone with the ability to bend and absorb energy, while the hydroxyapatite, it provides the compressive strength. When they are aligned in parallel, they work together to resist both the tensile and the compressive forces. So this alignment allows the bone to withstand heavy mechanical stress during the normal function, so that the load, it is distributed along the collagen fibers and it is transmitted to the hydroxyapatite crystals that resist the compression along the same axis. The terminal portion of the principal fibers that inserted into cementum and bone, they are termed as Sharpe fibers. So these fibers, they originate from the principal fibers within the periodontal ligament. As the principal fibers, they extend from root to the surrounding bone, their terminal portion become embedded into cementum. So these are the Sharpe fibers. So the main purpose, the role of Sharpe fiber is to hold the tooth firmly within the bony socket. They are a shock absorber. Coming to the next question, the terminal edge of gingiva surrounding the teeth in a collar-like fashion, it's the marginal gingiva. Marginal gingiva is the gingiva that surrounds the tooth in a collar-like fashion. So this one is the marginal gingiva. The attached gingiva, it's the part that is firmly bound to the underlying bone and root of the teeth. So the attached gingiva, it is firmly connected to the bone, making it resistance to movement and provide the stability to the teeth. So your answer is B. The diagram is depicting the pathway of inflammation spreading from gingiva into supporting periodontal tissues. What does the arrow 3 represents? So the arrow 1, it represents the pathway that begins in gingiva and then spread to the supporting structure of the tooth. It moves to the loose connective tissue and then enters the bone through the tiny channels. Figure B2 represents the inflammation begins in gingiva and travel along the outer surface of bone. It can either enter the bone marrow through small channels. So this pathway does not involve the periodontal ligament directly. Whereas the arrow number 3, it represents the inflammation. It can spread from the gingiva into the PDL ligament. So this is less frequent pathway where the inflammation directly affects the periodontal ligament that support the tooth. The inorganic content, it is highest in the enamel. It's 97%. Predominant matrix metalloproteinase in periodontitis, particularly MMP 8 and 9, they are derived from polymorphonuclear leukocytes. So these are primarily produced by PMNs and play a significant role in degrading the type 1 collagen, a major component of the gingival and periodontal ligament. So we have already discussed how they occur, how they cause, how they degrade collagen. Up to what percentage of depth of periodontal pocket mouth rinses penetrate? The answer is 4%. So that means that mouth rinses can effectively penetrate only about 4% of depth of periodontal pocket. So they are largely restricted to supragingival areas. Mouth rinses, they are less effective in reaching and cleaning the deeper portion of pocket where bacteria and debris can accumulate. While scaling subgingivally the tip of curette, it breaks down. All of following action are taken to try and remove this tip except. So the answer is use of push stroke to force the tip out of sulcus. So pushing the tip further into the sulcus, it can complicate the situation. So it is not recommended to use force to push the fragment deeper. Gently examining the gingival sulcus. Yes, you should gently examine the sulcus using a curette in a spoon-like stroke, attempting to pull the fragment out. Taking periopical radiograph, it can help to locate the position of the broken tip, allowing for a more precise approach to retrieve it. Placing the patient in upright position, it can help to prevent any potential aspiration or ingestion of the broken tip. So that is why answer is A. If a patient experience sensitivity while being scaled with an ultrasonic device, all of following action would be appropriate to counter this problem, except which one is inappropriate. The answer is B. Proceeding to another teeth and then returning to the sensitive tooth later in the appointment. So this can give the sensitive area some time to recover before continuing the treatment. Making necessary adjustment to water spray. Adjusting the water spray to increase the cooling can help to manage sensitivity and reduce the heat generated by the instrument. Using less pressure, reducing the pressure on the tooth during scaling can help to prevent the damage on the tooth surface. So answer is B. How should be the periodontal probe inserted into the sulcus? So periodontal probe should be inserted parallel to the tooth surface. So the probe, it should be gently walked around in up and down motion while remaining under the gingival margin. So this technique will allow for the accurate measurement of the depth of sulcus or the pocket and help to assess the level of attachment loss. When using the periodontal probe to measure the pocket depth, the measurement you take it from the base of pocket to the cemento-enamel junction. So that can help to assess the depth of the pocket and level of the clinical attachment loss. Junctional epithelium, it is attached to tooth by, the junction epithelium, it is attached to tooth by the epithelial attachment. Remember the external basal lamina, it faces the connective tissue, whereas the internal basal lamina, it will faces the tooth. The external basal lamina, it will face the connective tissue, whereas the internal basal lamina, it will face the tooth surface. So the external basal lamina of the junctional epithelium, it attaches the epithelium to the connective tissue of the gingiva. So external basal lamina is not your answer. Answer is epithelial attachment. And the internal basal lamina, it unites the epithelium to tooth surface, specifically to the enamel. In gingivitis, the main fiber groups affected are the circular fibers. So in gingival inflammation, the main fiber group they are affected, they are the circular and dentogingival fibers, dentogingival and the circular group. So answer would be circular group here. The gene for the class 1 and class 2 human leukocytes, they are seen on the chromosome number 6. With the age and onset of menopause, the degree of gingival keratinization it decreases with age and onset of menopause. So that means that gingival tissue become less keratinized as the individual ages or grow through the menopause. The soft tissue wall of the gingival sulcus, it is formed by the marginal gingiva. The marginal gingiva, also known as free gingiva, it constitutes the soft tissue border at the edges of gingiva, and it forms the soft tissue wall of the gingival sulcus. Oddland bodies, they are seen in stratum granulosum. Oddland bodies or keratinosomes, they are found in stratum granulosum. So these structures, they are important in the process of keratinization. So stratum granulosum contains keratohyalin granules, contains Oddland bodies. So these bodies will regulate the permeability of epithelial barrier function. Puberty gingivitis, it will affect puberty in gingivitis, it can occur in both male and female. So it is characterized by gingival enlargement. So the hormone changes that take place during puberty can contribute to development of gingivitis in adults. The most of co-aggregation among the strains of different genera, they are mediated by, in the process of the co-aggregation, the lecithin-like adhesion, it plays a significant role. So these adhesions will be responsible for mediating the interaction and adhesion between different strain of microorganism. So co-aggregation, it is a process in which a different type of microorganisms, they come together and adhere to each other, and lecithin-like adhesions are the key factor in this process. Co-aggregation, it can be inhibited by substances like lactose and galactosides. So answer is B. The red complex, it is formed by all except, the answer is B. So remember, the red complex, it is formed by P. gingivalis, Treponema denticola, Tenerelia forsythia. So the orange complex is formed of P. intermedia, Fusobacterium nucleatum, C. rectus, U. bacterium species, and the green complex, Capnocytophaga species, Echinilla species, and the violet complex, it is formed by Agribacterium actinomyceticommittens. So answer would be B. Through the adult life, the position of mucogingival junction, it remains stationary. So because the mucogingival junction, it remains stationary throughout the adult life. So mucogingival junction, it is a boundary between the attached gingiva and the alveolar mucosa. It remains in fixed position throughout an individual adult life. The changes in the width of attached gingiva, they are caused due to variation in the position of the coronal and of the attached gingiva rather than the movement of the mucogingival junction itself. So answer is A. So supragingival calculus rapidly occurs in the lingual area of the mandibular incisors. The supragingival calculus, it is a white or whitish yellow in color and it has a clay-like consistency. It occurs more rapidly in the lingual surface of the mandibular incisors. The strawberry gingivitis, it is seen in Wagner granulomatosis. So Wagner granulomatosis, it can present with the classy strawberry gum appearance, characterized by enlarged and inflamed gingival tissue. The bleeding on probing appears in which stage of gingivitis? It is seen in early stage of the gingivitis. The bacterial adhesion on tooth, it is prevented by myeloperoxidase. Myeloperoxidase, it is enzyme that is released by leukocytes and it has bactericidal properties. Myeloperoxidase can inhibit the attachment of bacteria to the tooth surface. So when a body detects the presence of bacteria or foreign pathogen in oral cavity, the immune respond by sending leukocytes to the site of infection. So these are generally the neutrophils or the monocytes. So they will release myeloperoxidase as part of the defense mechanism. So myeloperoxidase, it is an enzyme that contains hypochlorous acid. When it comes into contact with the hydrogen peroxide and chloride ion that are present in the oral environment. Hypochlorous acid, it is a potent bactericidal and it can effectively kill or damage the bacteria. So myeloperoxidase not only attacks and neutralizes the bacteria, but it has a benefit of inhibiting the attachment of the bacteria to the tooth surface. So by disrupting the ability of bacteria to adhere to the teeth, the myeloperoxidase, it prevents the formation of the plaque. Not a primary colonizer of plaque, it's the S mutants. So remember the primary colonizers, they are S mitis, S oralis, S sanguis, Streptococcus species, S intermedius and S gordoni. So your answer would be C here. The commonest cause of gingivitis is the local irritants. The gingivitis, it is primarily caused by presence of local irritants like the dental plaque that accumulates on the teeth and irritate the gingival tissue. The major supply of the periodontal ligament, it comes from the periosteal vessels. The major supply is from the vessels branching from the periosteum that surrounds the alveolar bone. So the periosteal vessels, they play a role in providing nutrient and oxygen to the periodontal ligament. What are the changes that are seen with the menstruous cycle except the answer is decreased clavicular fluid of the normal gingiva? So during the menstrual period, several oral and gingival changes can occur such as bleeding gums, increased salivary bacterial count and tense feeling in the gums. However, the clavicular fluid, they are unaffected during the menstrual cycle. The bacterial enzyme capable of causing breakdown of the ground substance of periodontal ligament is the hyaluronidase. So hyaluronidase, it is an enzyme that is produced by certain bacteria and it is known to degrade the hyaluronic acid, that is component of the ground substance of the periodontal ligament. So this enzymatic activity can contribute to tissue damage in the periodontal ligament. Other enzymes like collagenase, Mcqs, they can also play a role in degrading collagen within the periodontal ligament. The most unreliable feature during the diagnosis of gingivitis is the stippling. Stippling, it's a pebbly or orange peel-like appearance of gingival tissue and it is primarily observed in the attached gingiva. So the absence or presence of stippling alone may not be a definitive indicator of the gingival inflammation. So a more reliable diagnostic sign of inflammation in gingivitis is presence of bleeding on probing. Which part of gingiva it is first affected in gingival hyperplasia? It's the interdental papilla. Brushite crystals form of calculus. They are morely seen in mandibular anterior region, whereas magnesium white log, it is seen in posterior region. The predominant microorganism that is isolated from localized aggressive periodontitis lesion, it's the Actinobacillus actinomycetamens comitans. The answer is D. Dental flossing is not done in pediatric pedo patients because of the open contact points between the adjacent primary teeth. So children, they have gap or open contacts. So that is why flossing is not necessary or recommending in the situation. So the answer is C. The purulent exudate from the gingival sulcus is an indication of. So purulent exudate from the gingival sulcus, it is primarily an indication of the nature of the inflammatory changes in the pocket. So it does not necessarily indicate the depth of pocket or severity of the destruction of the supporting tissue. So purulent exudate, it is a secondary sign of inflammation and it is associated with the character of inflammatory response in the periodontal pocket. The primary cells present in the oral epithelium, they are the keratinocytes. The principal cells, they are the keratinocytes. They are responsible for synthesizing keratin, leading to formation of keratinized stratified squamous epithelium. So the keratinocytes, they account for 90% or more of the gingival epithelium. The thickness of periodontal ligament, it is maximum in, so it is the periodontal ligament, it adapts and responds to forces placed on the teeth. In teeth with a heavy function, the periodontal ligament, it tends to be thicker as it accommodates and distributes these forces to support the teeth. In contrast, disuse or reduced occlusal forces can lead to atrophy of PDL that results in thinner PDL. The keratohyanin granules, they are basophilic in nature. So these are found in granular layer of epidermis and are involved in formation of keratin. So they stain basophilic, they appear blue or purple when stained with the standard histological stains. What is true in relation to the active pocket? An active pocket is associated with current loss of epithelial attachment. That is a sign of ongoing periodontal disease. In an active pocket, the bone is being lost due to progression of the periodontal disease. Active pockets, they are often diagnosed clinically by presence of bleeding, either spontaneously or on probing. So this bleeding would indicate inflammation and ongoing disease activity. So all of the statements are true in relation to the active pocket. In which of following condition is the role of microbial plaque most obscure? The role of the microbial plaque, it is obscure in desquamative gingivitis. The pocket epithelium shows a series of histopathological changes. So in the histopathological changes observed in pocket, both proliferative and degenerative changes can be seen. So that represents the interplay of destructive and constructive tissue changes that takes place in the periodontal pocket. Which brushing method is recommended for patient after periodontal flap surgery? It's the Charter method. Pellicle, it is composed of glycoprotein. Erythema and bleeding on probing, they are evident in the early lesions. The sequence of developing gingivitis is, the answer is B. Initial, early stage, established lesion and the advanced lesion. So that's the sequence.